Our project was on care rationing during the COVID-19 pandemic.
What is healthcare rationing? Healthcare rationing is used to determine how to allocate limited resources in a time of dire need. While there have been many definitions of healthcare rationing, as a general term has been defined as restricting the access of some people to useful or potentially useful health services due to budgetary limitations. These budgetary limitations are not just restricted to financial constraints, but also resource constraints as well. As stated before, these are the bottlenecks that force healthcare providers to have to ration. A slight history on rationing. For this project specifically, we were talking about COVID-19 specifically, which is a relatively new topic, and there's a general lack of information due to that fact. However, rationing in healthcare is not a new subject at all. There's a couple types of rationing. One is self-rationing, which is making the choice to actively not seek medical attention or medication. Insurer rationing, insurance companies put limits on how much they can give you in terms of assistance. This is normally determined by how much you're paid for a premium. However, many people also see this as a form of self-rationing or encouraging self-rationing because they determine how much they can help you, and then you have to, based on your income, determine if you can afford medication for that month or if you can afford to go to the doctor or not. There's government rationing, which is the medical programs such as Medicare and Medicaid. These are medical assistance programs that you can sign up for through the government, and they will help give you pay for medical assistance. And then there's healthcare provider rationing. Healthcare providers are unable to provide or accommodate the volume of patients that are seeking medical assistance. This is what we're mainly focusing on because as we saw at the very beginning of the pandemic, there were multiple times where there were emergency hospital setups in places like parking garages. A slight continuation of rationing. There have not been any specific cases that are considered landmark cases in the realm of COVID, but there have been multiple in terms of pharmaceuticals. Pharmaceutical companies have created monopolies over medication, causing prices to skyrocket. One landmark case most recently was settled on October 1st, 2021, where 3 companies paid over $400 million over price fixing claims. This is considered healthcare rationing because they get to determine who has access to their medications or not.
Okay. Why this topic? The COVID-19 pandemic has such a prevalent issue for the last 2 years and has taken a massive toll on our healthcare system. During the start of the pandemic, we witnessed areas with highly dense populations suffer due to lack of resources, multiple cases of emergency hospitals being built in parking garages due to lack of space and available beds inside the hospital. This brings forth the question of who out of a group gets the access to these resources in their time of need, and how healthcare professionals can decide ethically and humanely.
When determining care rationing, it's really important to use a wide variety of proposals and protocols because it really does change depending on what state you're in, what institution you're working at, or what pandemic has hit. So there's not one specific rules that all places abide by, but it's variable. So when you look at the pandemic models right here, the last pandemic that had a good model was the influenza pandemic. And this chart compares the COVID pandemic to that one. And you can see that there's a lot of different things that I have circled here that change what protocol would be enacted. For example, the deaths are very, very different for both. So you would take different measures for that. The risk population, age comes into account, what number of population is what age, where the pandemic originates, if it's within our country or not, and the economy. The economy is very different than it was for 1918's pandemic, as you can see in the bottom row. So that comes into a big account when determining what to do with care rationing. So this is a specific model from the New England Journal of Medicine, and this highlights 3 core main values that they use when doing the cost-benefit analysis of each sort of care rationing. So the arrow indicates a category. We have maximizing benefits, treating people equally, promoting and rewarding instrumental value or the benefit to others, and to give priority to the worst off. So these are all things that they use to evaluate what comes out of it. And if you look in the right column from the article, it shows you what they applied to the COVID pandemic. So for example, under the treat people equally column or row, it says that first come, first served shouldn't always be used, and that maximizing benefits of saving the most lives would come into the highest priority in this circumstance. But the quote I have in the bottom left corner does talk about how fair allocation requires a multi-value ethical framework that can be adapted depending on the resource and context. So that just re-implements the fact that the type of pandemic you're working with, at what point in the pandemic, that all changes for how to care ration, and that there's not one correct answer, but many depending on where you are. And finally, just highlighting another type from another resource of pillars and values that are used during care rationing. So 4 pillars brought to us by the US National Library of Medicine says that we should maintain transparency, inclusiveness, consistency, and accountability throughout the entire care rationing process, and that the core values are to balance autonomy, beneficence, and distributive justice, which we've talked about in class. And the NCIB showed us this diagram, which shows all the types of ethical considerations that go into considering a care rationing response for a pandemic. So it's things like equity and stewardship and individual liberty, privacy, and duty of care. All those categories have to do with the decision of how to figure out care rationing.
So the case study that we're going to be analyzing in our project has to do with rationing care in COVID. So in April 2020, a hospital in rural Midwest is almost at capacity in their ICU unit, with the majority of their beds being filled with COVID-19 patients. There's a single bed left open, but there are 2 patients recently diagnosed with COVID-19 in critical condition who need to be placed in the ICU in hopes to get better. The first patient is a 65-year-old man who has just been recently diagnosed, yet already has extremely low oxygen levels, difficulty breathing, and a history of heart attacks and COPD. The second patient is a nurse at the pediatric hospital next door. She's a 35-year-old single mom with 2 young children at home. She has had the virus for 5 days now, but it has unfortunately developed into a serious case of pneumonia. The ICU care team must decide which patient will get the last bed, as both patients are currently in the emergency room with conditions that are worsening. So to evaluate this ethical issue, we're going to use a 6-step process. It's a process to guide ethical decision-making in healthcare, and working through these set of steps ensures that we are bringing a comprehensive lens to handling ethical disputes or problems.
So the first step is to gather relevant information. And one of the most important things to look at is the fact that their ICU is at capacity and that there's only 1 bed left with 2 patients who are in need. And we need to look at the different facts surrounding these 2 patients. And the first patient is a 65-year-old male. He was recently diagnosed with COVID, but he has very low oxygen levels, difficulty breathing, and a history of heart attack and COPD, which means he'll likely need a ventilator to survive. And then we have our 35-year-old female patient. She has had the virus for 5 days. She has 2 young children, and she developed a serious case of pneumonia. She also needs an ICU bed to monitor pneumonia coupled with COVID-19.
Step 2, identify the type of ethical problem. An ethical dilemma is a situation in which a difficult choice has to be made between 2 courses of action, either of which entails transgressing a moral principle. The moral dilemma lies between 2 patients suffering from the same disease, but with very different backgrounds. The first patient is a 65-year-old male that has many pre-existing health conditions and hypoxemia, low oxygen levels in the blood. The second patient is a 35-year-old female who sustained mild conditions over her first 5 days with the virus, yet has developed a serious case of pneumonia. She's young, without pre-existing health conditions, and is a sole caretaker of 2 small children.
So the third step of the 6-step process is to use ethics theories or approaches to analyze the problem. So below, we thought of 3 different theories or approaches that we could use to address this issue. So the first one, and probably the biggest one, would be ethical reasoning. And that's a moral decision based on gathering information and correctly applying ethical principles in decision-making. And and it allows us to recognize and analyze and clarify the ethical problems and just decide what the right thing to do is by just like looking at the pros and cons and the right and wrongs of ethical decision making. And then another approach would be a caring response. And this is an ethical goal that is key to honoring a patient's dignity. It also optimizes positive results and minimize damage to the patient. So it's more like patient-centered care, making sure that the patients are both being treated equally and getting the help that they need. And finally, the last approach would be patient rights. And that's just ensuring that these patients are getting high quality care and that there's shared decision-making between the healthcare providers and the patients.
Step 4 is to explore the practical alternatives. What this means is to seek viable alternatives and find the one that most fully approximates or achieves a caring response. So the alternatives that we came to were to locate another facility that had open beds. If another facility was found that had an open bed, we would transfer the patient who is healthier so that because they're more fit for travel, and that patient would be the 35-year-old female. So she would be transferred and have a bed there and get treated, as well as a 65-year-old male who would stay at our facility and take the one bed that we do have open. We made this decision because a 65-year-old male is not fit for travel. During COVID-19, the typical mode of travel for patients like these were by plane or by ambulance, and due to his state, he would not be fit for that transportation. If no bed is found for in another facility, then the patient with the higher probability of survival will be given the bed. In this case, that patient would be the 35-year-old female. She's younger, healthier, and has sustained the virus for 5 days prior to the pneumonia. So she has a better chance of survival in this situation. Her condition is more treatable, whereas the 65-year-old male may not be treatable, and that would leave 2 patients untreated. So we want to kind of go with the life-saving probability aspect.
Step 5/6, complete the action and evaluate the process and outcome. The completed action for this case was another bed was found at a different facility. We decided the best ethical decision is to transport the woman to get to that facility. By doing this, we can give the man the bed in the ICU and treat him, as it is not safe for him to be transported due to his age and symptoms. The woman has a higher survival rate and has been living 5 days with the virus. The outcome: both patients received an ICU bed, and both patients have been treated for their symptoms. Evaluation: we showed a caring response. No patient was left untreated. The decision was made together, and we had a moral obligation to treat both patients suffering, and we followed through with our obligation.